Hi. In this lesson, we are diving into ovarian torsion. Ovarian torsion is a gynecological emergency that requires rapid recognition and management to preserve ovarian function and prevent further complications. Ovarian torsion refers to partial or complete rotation of ovaries or fallopian tube on its ligamentous supports. As a result of this twisting, the blood vessels also get twisted and it leads to vascular compromise and ischemia. Before we go into further details, now we shortly discuss the epidemiology. This condition is uncommon but critical. This condition can affect women of all ages, but primarily reproductive aged women are affected, like between 25 to 35 years. 60 to 70% of cases occur on the right side due to sigmoid colon, limiting left ovarian mobility. In other words, sigmoid colon on the left side of abdomen play a protective role and it doesn't allow left ovary to rotate easily. What are the key risk factors that are involved in ovarian torsion? First are adnexal masses. Cysts or tumors, especially more than 5 centimeters, increase torsion risk. The other risk factor is pregnancy. During pregnancy, hormonal changes occurs and as a result, ovary becomes enlarged. These two factors predispose to torsion, particularly in the first trimester. The third risk factor is prior pelvic surgery. Due to surgery, anatomy of pelvis get altered. If the patient have prior case of torsion, then there is increased risk of ovarian torsion. Let's move to the pathophysiology of ovarian torsion. How torsion happens? The ovary is suspended by two ligaments. One is infundibulopelvic ligament and the other is ovarian ligament. These ligaments attach ovary to lateral side of uterus and pelvic side walls. When ovary twists, the torsion of vessels and ligaments also happens and it results into vascular congestion and hemorrhage inside the ovary. First of all, torsion obstructs venous and lymphatic outflow. As a result, edema and ovarian enlargement happens. Subsequently, arterial compromise leads to ischemia and eventually necrosis. Now we see how a clinical case of ovarian torsion is presented. The hallmark symptom for ovarian torsion is severe unilateral lower abdominal and pelvic pain that is seen in the 90% of cases. This pain is sudden in onset. The patient may describe sharp or colicky pain that radiate to flank and even thighs. Other associated symptoms like abdominal and nausea and vomiting occurs in up to 70% of the cases, and low-grade fever is a late sign, and this sign is related to necrosis. These are all the symptoms of ovarian torsion. Let's suppose a patient of age, suppose 25 years comes to the clinic with a complaint of sudden onset, like severe unilateral abdominal pelvic pain and nausea and vomiting. Then we can suspect the patient is suffering from ovarian torsion, but we can't make a diagnosis. We just have to go into further details. The next step is examination finding. In pelvic exam, unilateral adnexal tenderness and a possible palpable mass is observed. For vital signs, if you notice tachycardia and hypotension, then we can say that patient is suffering from advanced ischemia. Let's have a look on the diagnostic tools. Imaging is supportive but does not provide definite diagnosis but still holds a cornerstone place. The first approach is transvaginal ultrasound. What we see in the transvaginal ultrasound, we see enlarged ovaries. The normal size of ovaries in the reproductive age is between 1 to 2 centimeter, but in this case, we see the size is more than 5 centimeter. Peripheral follicular string of pearls, free fluid or twisted vascular pedicle, whirlpool sign. This point is important regarding exam. And it is a pathogenomic hallmark for ovarian torsion. In Doppler technique, we commonly notice absent venous flow. Absent arterial flow indicates poor prognosis. Firstly, we notice that venous flow is not present. Then if there is also obstruction in the arteries, in this case, we can say that the prognosis is poor. CT and MRI techniques are applied if ultrasound is not responsive. Like if it does not give any result, then we go for CT or MRI. Findings include reduced contrast enhancement or ovarian displacement. In this radiograph, you can see that the right pedicel have enlarged due to blood supply obstruction, and will pool sign is also noticed. Let's move to the management portion. Keep in mind that this is an emergency situation that requires urgent surgical approach. For surgery, we don't go with traditional approaches. We just go for a technique called laparoscopy. Laparoscopy is the gold standard for diagnosis and treatment because it provides direct visualization. In laparoscopy, a surgeon make a small incision inside the abdomen and pass a device called laparoscope. This consists of a flexible tube. At the end of the tube, a camera is present that give a direct visualization. And with the help of that camera, surgeon untwist the ovary. If the untwisting is performed within 8 hours, it increases the salvage rate up to 90%. The ovaries are necrotic. We still go for the laparoscopy because studies have showed there is return of ovarian function after the detorsion or untwisting. As I have described, the hallmark symptom for ovarian torsion is severe pain. For the pain management, we used IV analgesics. And if there is any chance of secondary infection, then we go for antibiotics.